Good afternoon, friends, from Maharashtra Ophthalmological Society. First of all, we wish you a very happy Independence Day. It is on this great occasion that Maharashtra Ophthalmic Society is thrilled to organize the Teachers of Tomorrow zonal rounds today. We all know that Teachers of Tomorrow is an interesting concept. It is an intercollegiate team event competition which is going to happen today between the postgraduates. TOT, how it is called as, is an opportunity for all our postgraduates to showcase their teaching abilities. And each PG institute, which is going to be showcasing today their best of talents in the form of two postgraduates who have been already allotted two topics, one each, and they are going to present their best teaching skills in a manner which is going to be done by in about 4 minutes. Such 6 teams are going to be represented. This zonal round that we are currently conducting right now is of Western Zone. Along with me, we have the Maharashtra Ophthalmological Society's Managing Committee member, Dr. Aniket Patil from Kolhapur. I will request Aniket to discuss about the rules. But before we come to that, I would like to also thank and welcome our judges, Dr. Akshay Nair. Dr. Akshay is a oculoplastic surgeon at Aditya Jyoti Eye Hospital and Advanced Eye Care in Mumbai. He's an alumnus of prestigious Shankar Nethralaya and LV Prasad Eye Institute and has been always involved in teaching activities. Along with Akshay, we have Dr. Jyotika Mishri Kotkar ma'am. She is from, madam is a head of department and she is a comprehensive ophthalmologist. We are very honored to have her as a judge. And along with her, we have Dr. Shubhangi Sathe madam. She is head of department at the SNDT Medical College in Nasik and has a special interest in neuro-ophthalmology. So with 3 of our judges on board, we also welcome all the mentors and postgraduates and wish them all the best. And now I hand over to the main coordinator for today's session, who is Dr. Aniket, our managing committee member. Over to you, Aniket. Thank you.
Yeah, good afternoon, everyone, and a very happy Independence Day to everyone. Our session is session number 6, which is Western Zone 2. There will be 6 colleges which will be competing in this session. The colleges are Nandadeep Eye Hospital, DY Patil Kolhapur, DY Patil Pune, Bharati Vidyapit Sangli, Bharati Vidyapit Pune, and Krishna Medical College Karad. So 2 postgraduate students from each of this college will be presenting, giving a presentation for the allotted time, that is 4 minutes. All these postgraduate students have been given this topic a week prior, and I'm sure they're all prepared well, and we are looking forward for your fantastic presentation. We'll be going in a specific order. Dr. Nandadeep Hospital would be first, then would be DY Patil Kolhapur, then Bharati Vidyapit Sangli, Krishna Medical College Karad, Bharati Vidyapit Pune, and then DY Patil Medical College Pune. That is the order in which we have submitted the name of the PGs to our judges. So to avoid any confusion, we'll be just going in the same order. Even the order of the postgraduate student is fixed. I'll be letting you know who is the next presenter, and accordingly that particular person can share the screen and give his presentation. The presenter will get 4 minutes to present his talk. There'll be a timer on the right side of your screen when you are presenting your topic. You have to adjust according to that. Finishing your topic within the allotted time does carry weightage and will give you extra mark or whatever the mark if you present it properly within the stipulated time. Your content, presentation, innovation that you use, the way you talk, everything will carry weightage in your marks. At the end of your presentation, one of the judges will question you about your topic. That again will carry 1 mark, and that's pretty much sums it for one student. And after that, we'll have to move on to the other student. Both students will be given marks out of 10. So the entire college or the hospital will get marks out of 20. So at the end of this session, we'll just sum up and declare these marks will be submitted to the chairman of scientific committee, and they'll then declare the winners and all the stuff. Do we have everyone here, or should we start with the presentations now? Anything else that needs to be clarified from my part to the students or mentors or judges?
I think we can go ahead.
Okay. Then the first college would be Nandadi Pai Hospital, and our first presenter for the day is Dr. Vaishali. I request Dr. Vaishali to share her screen.
Dr. Aniket, may I just ask you one question? Are you keeping the timer on?
The timer will
be you'll be pressing a bell or something like that, so that we know that the time is up.
Okay, I'll see whether I can arrange a
because
bell.
it will be better, because in 4 minutes we are strictly going to adhere to the time, so that's why.
I'll just sort of interrupt in between if possible. But
Yeah,
if
yeah,
I am able to arrange a bell, just 15 seconds to go.
Whatever. Yeah, something like that. Yeah. Thank you.
Thank you. Dr. Vaishali?
Yes, sir. I'm sharing.
You can share your screen.
So, good afternoon, class. As we all know that FACO was introduced long way back, nearly in 1970s, but it is gaining importance nowadays only. Reason being, lot many side effect that was associated with FACO due to lack of awareness about OVDs. One such case is the intumescent mature cataract, in which we have increased intralenticular pressure and shallow anterior chamber. So you may have Argentina flag. So now how to prevent it? You have to match this raised intralenticular pressure by the heavy OVD placed in the anterior chamber. So we use soft cell technique that is described by Arsenov, and it is most commonly used for hard mature cataract, in which first we use the dispersive agent to coat the endothelium, and then we use the cohesive agent to maintain the anterior chamber and to put pressure over the capsule. So each OVDs have different physical properties, like they have elasticity, they have viscosity, they have pseudoplasticity, that is the ability of the substance to transform its state, like from solid to liquid under pressure. So this property help OVDs to to remove easily. And then we have obviously the coatability and the surface tension. So we'll see one by one in detail. First is viscodispersive agent. They have low pseudoplasticity, so we cannot remove it easily. They have low surface tension, so they coat the endothelium better and protect it. For example, we have 2% HPMC, that is hydroxy propyl methyl cellulose. It is least expensive but very good viscodispersive. Then in this class, obviously we have heavier viscodispersive, which is in the combination of 3% sodium hyaluronate and 4% chondroitin sulfate, and it is known as viscode. So it is heavier than HPMC but have the similar properties. So this viscodispersive agents are most commonly used OVDs. Then we have viscocohesive agents. They have high pseudoplasticity, so very easy to remove, but they have high surface tension. But the good part is they adhere it onto themselves really well, that they maintain the space really well. So we used it in the special conditions, like for IOL exchange, or also during insertion of IOL. So the example is 1.4 or 1.5% hyaluronate. Then next we have the visco-adaptive agents. So we are not use them widely nowadays, obviously because we have the better OVDs like viscodispersive and cohesive. But one property is that at lower flow rate, they act as the cohesive material, and at the higher flow rate, it acts as the dispersive material. So example is 2.3% sodium hyaluronate. Now, where can we use it? We can use in the cataract surgery to coat the endothelium to maintain the anterior chamber. Then we use in the glaucoma surgeries to open the Slem's canal. Then we use it in the keratoplasty for proper trephination, even and circular trephination. In posterior segment surgeries to coat the cornea, and in the perforating injuries to maintain the globe. Then removal of OVDs after surgery is really important. If failed to do so, it may lead to the complication, like it post-operatively increase the IOP. Then it can cause capsular bag syndrome or capsular distension syndrome. In this, the OVDs is trapped between the lens and the posterior capsule, and it may cause induced myopia. How it looks, you can see the first picture, where this is a slit lamp examination, in which you can see this white shadow is due to the turbid fluid, and below that is the anterior segment OCT, where you can see the hyperreflectivity due to this turbid OVD, whereas in the left normal eye, both is absent. Then you can also have the pseudo anterior uveitis. So this was the brief from my side. Now I want you guys to read it properly in detail, and then we'll discuss in next class. Thank you.
Very nicely presented, Dr. Vaishali. I would
Thank
like
you,
to
ma'am.
ask you one question
Yes,
that
ma'am.
sometimes you must have seen that there is an iris gets caught in the phaco tip while doing phaco. So if this happens, which type of viscoelastic device would you like to use and why? You understood my question?
Ma'am, can you repeat?
Sometimes iris gets caught while doing phaco.
Okay.
So if such a situation arises, which type of ocular viscoelastic device would you use and why?
Okay, so as I tell you, you will read in detail and we'll discuss it later. So this is a good question. I'll tell you in the next class.
Thank you.
Yeah, if you can stop screen share,
Yeah.
then the next presenter can load it.
The second presenter from Nandadeep Hospital would be Dr. Neha. She is not presenting, right, Vaishali?
Yes, sir. Yes, sir. She's not presenting, sir.
So judges just make a note that they have only one PG from their college who's presenting. So
Dr. Aniket, I would like to know the time. I mean, how many minutes did she speak?
she completed it in time, ma'am. Just 5 seconds before she completed.
Okay, fine.
Yeah.
She should not be too short also. That's why I was just wanted to
She
know.
completed it just 5 seconds before the this thing.
Okay. Thank you.
So we'll move on to the next college, that is DY Patil Medical College, Kolhapur. I request Dr. Astha. Is Dr. Astha here? Dr. Astha? Anybody representing DY Patil Medical College, Kolhapur, you can just speak up on her behalf.
Dr. Asta, is Dr. Asta audible?
Gayatri, your voice is cracking actually. We can't hear you properly. Yeah. Yes, Gayatri.
Hello, sir.
Yeah.
Can you hear?
You have put yourself on mute mode. Can you just come out of mute mode? Gayatri, are you there? In that case, can we go on to the other college, or should we wait for them?
No, sir.
Yeah,
Yeah,
Gayatri is talking.
Sir.
Yeah. Yes, Gayatri.
Is
Hello.
Astha's screen visible or is her audio visible? Audio.
Gayatri, if two of you are sitting in the same room, we also hear echo there. Uh, don't put on two devices in the same room if you're doing that.
They seem to be having some problem with the connectivity, I suppose. Can we move on to
Yeah.
the next college and come back to them later?
Yeah,
Yes,
we can
yes.
do that.
I think
We
that
can
is
do that.
better. Yeah. Aniket, we can go to the next one. Yeah.
Next college. Okay. The next college is Bharati Vidyapit Sangli. Do we have Dr. Subhashri here?
Yes, sir. I'm there, sir. Good morning, sir.
Okay. Subhashri, you can just share your screen.
Okay, sir. Just 1 minute, sir. Just
Yeah, Subhashri.
sir, I'm done. Actually, is it visible, sir?
No,
Hello.
it's taking time. It will come. It will come.
No, sir.
Had you tested it before, Subhashri?
Yes,
Before
sir.
the
I
session
did.
started? Yeah.
Yes,
Had you
sir.
tested? It was working fine then, right?
Yes, sir. Right now, so in my screen, it is visible, sir.
But it's not.
We can see that an iPhone has started screen sharing.
Yeah, it started. It's
If you're
in process.
using mobile data and not Wi-Fi, then it does take time.
Sir, it is mobile data.
Subhashri, you are presenting from a phone or from your laptop?
From my phone, sir.
Okay, phone. Okay. Do you have any possibility of maybe joining from your laptop if you are having issues with your phone?
Yeah, yes, sir, but will take some time, sir. Like,
Is the other person is Nisarg presenting on laptop? Dr. Nisarg, the other presenter from Bharati Vidyapit Sangli. Are you here, Nisarg? By the time Subhashri solves the issues, probably Nisarg can give his presentation. Is Nisarg here?
Teachers of tomorrow also need some technical training in getting connected.
sir, is it visible right now, sir?
No, I think you can stop sharing and then try again maybe.
Yeah.
And is your other PG there with you, Mr. Dr.
Nisarg. Yeah.
Oh, he's not there along with me, sir. This must be.
No, but is he there now?
But
Anil?
is he signed in? I'll just see. Dr. Rajesh, are you there, sir?
Yes, sir.
Yes, sir.
Is Dr. Nisarg ready with his presentation? We can probably go ahead with his presentation before Subhashri is.
I will call him, sir. Just.
I think till then we can ask all the participants to be ready with their own laptops and preferably sit in different rooms or maybe.
Yeah, a valid point there. Everybody can take in that instruction. All the
And I
PGs who are
think
not present.
Dr. Nisarg, I don't see him in the
There's some
participant.
participants whose name is not completely visible, ma'am. So we don't know. It says
Okay,
just
okay.
iPhone
Some
or some
iPhone,
short
yeah.
form. Short form. So
True.
Subhashri, you can probably stop your screen sharing. So if both of them are having problem, they can sort out their issue, and instead of waiting for more time, because we have to complete this in a particular time limit, we can probably move on to the next college.
Okay, now it is seen. Is this, yeah, Subhashri, now it is seen. Your presentation is seen right now.
I can't see it here.
No, I can see it. Corneal anatomy and its significance. I think that's the
Okay.
topic.
Can
but
all
it,
the three judges see?
we
Because I
can
can't.
see it, but
I-
it is coming in a, it's in a phone screen format. So I
Yes,
don't think it's a
Well,
regular
it is
PowerPoint,
not in
or
the
she
slide
needs to
format.
start slideshow.
See, if all the three judges are fine with it, we can go ahead with it. Can we
They are
hear
fine.
it from all the three judges? Jyotika ma'am,
Yes,
Shubhangi ma'am, and
actually, I can see just the first slide or whatever you call it. Just
yeah.
saying
Okay,
Cornel.
then go ahead.
Yeah.
no, I can't see anything. I
Okay,
can.
then we'll have to wait till all the judges give a green signal. Probably then only we will. Is it okay with Dr. Akshay there?
Yeah, I can see.
Okay. Dr. Jyotika ma'am, what's the scenario there? It will come, because for me also it was not showing up, but it just currently started showing just now, just 2 seconds.
Okay, we can start then.
Okay, so it's a go ahead from everyone, right? Dr. Shubhangi ma'am, from your side?
Yeah, no problem. I can see it.
Yeah. Then Subhashri, you can probably start. Just a moment. Priya, can you start on the timer, please?
Okay, sir.
Yeah. Yeah, we are ready to go, Subhashri. Subhashri, hello? There's some network issue there, it seems, wherever she is.
And her second partner
I
was,
think we have lost her. We just saw
Yeah,
that. Now I
yeah.
can't see anything at all.
Yeah, we can't see anything at all. That's true.
Hello.
I think
so
Hello.
yeah, now.
yeah, so her partner is also not there, I think, right now, is it?
Yeah, Nisarg also has not responded as yet. They mentioned
Gayatri, I
Dr.
could see her
Rajesh
just
was
now.
here. Just
Hello,
ask
sir.
him.
Hello, sir.
Yeah, who's this? Yeah.
Sir, I'm
Dr.
Astha Vakasia. I'm logging from Gayatri's account, sir, actually. From
Okay.
DY Patil, Kolhapur, sir.
Okay. So the
Asta
second
Can we
and
one.
start
Gayatri,
from here only?
Asta and Gayatri, both of you are there, right?
Yes, sir. After my session, Gayatri will take.
Okay. You're doing it from the same laptop, right? So in case if
Is it
Subhashri has,
okay, sir?
yeah, it's okay. So in case if Subhashri is not working out, we'll just go to DY Patil Kolhapur. Asta, you can probably share your screen.
So is it visible?
Yeah, it is visible. Judges, just make a note. This is
Yes.
DY Patil College Kolhapur and Dr. Astha, the
And
presenter.
sir, am I audible also, na?
Yeah.
Yes, you are audible and screen also visible.
I'll just ask them to put on the timer. Once the timer is on, you can just start your presentation, Astha.
Okay, sir. Okay, sir.
So, Priya, can we have the timer on, please?
Yes, sir. It starts.
Yeah, start off.
Okay. Good noon, sir. Today I will teaching you contraindications of refractive surgeries. These refractive surgeries contraindications are divided into total two parts. First, Contraindications are divided into two parts: absolute contraindications and relative contraindications, and further divided into three parts: ocular, systemic, and medications. Absolute contraindications, let me start first. Ocular contraindications contain unstable refraction first. Refractory error should be stable with less than 0.5 diopter in spherical or cylindrical over 1 year. Second is the residual stromal bed thickness. It should be 250 microns for the standard. If less than that, it may cause post-operative ectasia. Corneal ectatic disorders like keratoconus and pellucidal marginal degeneration also includes. Other corneal degeneration, disorders like corneal edema, neurotrophic keratitis, and uveitis also includes. Uncontrolled glaucoma and severe dry eyes as it worsened after the surgery. Uncontrolled ocular allergies and blepharitis, exposure keratitis, pregnancy, and lactations are also absolute contraindications. Systemic contraindication includes uncontrolled connective tissue disorders, may risk of as stromal meltdown, uncontrolled diabetes, poor wound healing, and risk of infection, immune disorders like AIDS. Systemic medications, there are two. Isotretinoid used for the severe acne may increase the risk of dry eye, blepharitis, and conjunctivitis. Amiodarone used for arrhythmic heart conditions. It may cause poor wound healing, regression, dry eye, optic neuritis, or color halos. These all are the absolute. Now we'll go with relative contraindications. Ocular contraindication contain one eye status, amblyopia, post-ocular herpes, may risk of herpes keratitis recurrence, endothelial dystrophy, history of corneal and retinal surgeries, and a controlled glaucoma. Systemic contraindications contain controlled diabetes and connective tissue disorders, keloid, and systemic malignancy. Medicines contain sumatriptan used for migrations and hormone replacement therapy, as it may increase the regressions. Now I'm summarized with this little table. Contraindications have absolute and relative. Ocular absolute contraindication contain unstable refraction, residual bed thickness minimum 250 microns, corneal ectatic disorders, corneal edema, neurotrophic keratitis, uveitis, uncontrolled glaucoma, and severe dry eyes. As ocular relative contraindications are one eye, amblyopia, endothelial dystrophy, history of herpes keratitis, post-glaucoma and retinal surgery, and controlled glaucoma. Systemic contains uncontrolled diabetes, uncontrolled connective tissue disorder, pregnancy, and lactations, whereas relative contain controlled diabetes and connective tissue disorders. Medicines in absolute have isotretinoid, amiodarones, and relative has sumatriptan, hormone treatments. Now, my last take-home message is unstable refraction is most common contraindication. Control systemic disease like diabetes, connective tissue disorders are relative contraindications. Long-term use of medications should be asked while taking history or pre-operative checkup. And pregnancy, lactations are absolute contraindications. Thank you. And the last line I want to say, a good surgeon knows how to operate, better surgeon know when to operate, and the best surgeon know when to not operate. Thank you.
Okay, this is Dr. Sathe. Nice presentation. Congratulations.
Thank you.
You have almost all comprehensively covered all the contraindications. I have just one question for you. Maybe I am talking like a first year postgraduate student. I would like to know, ma'am, what is the problem? Like you said, controlled diabetes mellitus is a relative contraindication. You said controlled. You said even pregnancy. What do you mean by relative contraindication? Controlled diabetes. Why is it a relative contraindication? When would you like to do LASIK if a person with diabetes wants to get it done? Because what is controlled diabetes? I mean, I didn't understand that part.
Ma'am, like long-term sugar levels are like long-term managed. Then it's called as a controlled diabetes, and it will not cause a corneal edema if it controlled for long term. Like
that's what. So why do you want to say relative? Why is it a relative contraindication? It need not be a contraindication at all, right?
Yes.
So why do you say it's a relative contraindication?
If
because uncontrolled, you said it is contraindication, absolute contraindication. That I agree. But then you said controlled diabetes. If it is once it is controlled for a long time, as you said, Why should it be a that means all diabetics will be contraindications for
Yes,
LASIK,
ma'am, but
right?
it may be afterward, after surgery, it may increase. Like that's why it's
But then
relative.
how can you predict that? So when you say it's a relative contraindication, controlled diabetes, it means practically that no diabetic can undergo LASIK. Is it true? Or refractive surgeries?
No.
So yeah, you said controlled diabetes and you said something control also, like control connective tissue diseases. So what do you mean by controlled these? I mean, why should they be relative contraindications?
I mean,
That is my
we can
point.
see HbA1c if it is in like control, like less than 5 or like 6.5, then we can call it controlled.
Exactly. So it need not be a contraindication. It need not come under relative contraindication. That is what I'm trying to say. Anyway, thank you.
Okay, ma'am. Thank you.
Yeah. We'll move on to the next speaker from DY Patil Medical College, Dr. Gayatri. You can share your screen, Gayatri. Yes, we can see your screen, Gayatri. Priya, can we start the timer, please?
Am I audible, sir?
Yeah, you are audible.
Let's start.
Good
Just a
afternoon,
minute.
everyone. My topic is optic disc examination in glaucoma. What diagnosis of glaucoma depends upon the optic disc changes, irreversible visual field defects, and it may or may not be associated with raised intraocular pressure. Optic disc evaluation is important as structural changes in optic disc precedes functional changes in the visual fields. Approximately 40% of the axons are lost before the visual field defect develops. Examination of optic disc can be done by direct or indirect ophthalmoscopy or by slit lamp biomicroscopy. Normally, the optic disc is vertically oval and symmetrical in both eyes. The optic cup is placed centrally. The size of the optic disc is measured by the cup disc ratio, and it can be measured on the slit lamp or by the graticule method on the ophthalmoscope. The tissue between the cup and the disc margin is called as the neuroretinal rim, which is thickest inferiorly, followed by the superior and nasal quadrant. It is thinnest temporally. This is called as the ISNT rule. Now let us see the changes in optic disc in glaucoma. First is increase in the cup to disc ratio of more than 0.6. This should be suspicious of glaucoma. Asymmetry of more than or equal to 0.2 between the cup to disc ratio of both eyes in presence of similar disc sizes should be further evaluated. Loss of ISNT rule is an early sign of glaucoma. It represents retinal nerve fiber layer damage. Disc hemorrhages, that is splinter hemorrhages, which occur due to ischemic microinfarction, are seen on the disc margins. They are normally seen in normal tension glaucoma patients. As the cup enlarges, there is the shift of retinal vessels nasally. This is called as nasalization of the vessels. The characteristic appearance of the vessels being broken off at the disc margin is called as the bayoneting sign. Here we can see the double angulation of the vessels. Pulsations of the retinal arterioles may be seen at the disc margin. This is pathognomic sign of glaucoma. As the intraocular pressure further rises and the glaucoma advances, it causes posterior displacement of lamina cribrosa, causing deformation of the pores. It gives a porous appearance. This is called as a laminar dot sign. It is mostly seen in the superior and inferior poles. The retinal nerve fiber layer defects are seen in the temporal sector due to damage of the superior and inferior arcuate fibers. These defects are best seen with green or red-free filters. Normally, healthy retinal nerve fiber layer appears as bright striations, but defects can be of slit-shaped, wedge-shaped, or diffuse in nature. Peripapillary atrophy is usually seen surrounding the optic disc. It may be of alpha and beta type, but the beta one is characteristic of glaucoma. The end stage of glaucoma is glaucomatous optic atrophy, where all the neural tissue of the disc is destroyed and the disc appears white due to total cupping. This is called as the being caught sign. Now let us summarize all the changes. The changes in disc and cup are increased cup to disc ratio, asymmetry of the cup, and in advanced stage we see the laminar dot sign. In neuroretinal rim, we can see its thinning and loss of ISNT rule. In vessels, we can see nasalization, bayoneting sign, and pulsations. At the disc margin, we can see hemorrhages. Outside the disc, we see peripapillary atrophy and retinal nerve fiber layer defects. We should remember that not all cupping is glaucoma, and one should not enthusiastically overdiagnose glaucoma. Some conditions may mimic glaucoma as well. Proper documentation is necessary to study the progression of the disease, and for complete glaucoma workup, we should go follow other tests including perimetry, tonometry, gonioscopy, etc. as well. Thank you, sir.
Very nicely explained, Dr. Gayatri, in 4 minutes time explaining optic disc in glaucoma. What I would like to know is which is the best modality. We use 60 diopters, you mentioned 78 diopters and 90 diopters. So out of these three lenses, which will be the best one to see optic disc, slit lamp?
Better thing is to see on the slit lamp, and
No.
it can
Three lenses, which one will be the best and why?
90 diopters now.
Why?
Because it gives a stereopic view. More view is covered.
Okay. And
Ma'am, just sorry.
one more
Sorry.
one more thing, that how will you identify whether the disc is showing atrophy due to glaucoma or some neurological cause?
Yes. Ma'am, we first have to see the visual acuity. As soon as the patient comes, we will first see the visual acuity. If the visual acuity, there is rapid progression,
In the disc, how will we identify?
in the disc, pallor is more than cupping, it will be neurological cause, and we can compare that along with visual field defects. If the visual field defects are along the horizontal axis, it may be due to glaucoma, and in neurological defects, it is along the vertical axis.
Thank you.
Ma'am, just one question here. I had this question before also. When we are saying optic disc examination, the topic itself is a little confusing in the sense we are not asking optic disc changes, right? We are asking optic disc examination. So, what are the different modalities or the recent modalities in which optic disc can be examined? That is what I was contemplating rather than the changes, and that's why I had wanted the clarification as well.
Yeah. We had inquired it
Yeah.
with the scientific committee members of
Yes.
MOS, and just that's why I reverted back telling you that this is
Yeah.
the exact wordings which were given to the students. Optic disc examination in glaucoma.
True.
Yeah.
Yeah. So examination is important. Like, so different modalities of examining the disc effectively is what I probably would have looked at it like that as an examiner, or as a paper character, like, because you need to know the question properly, right?
Yeah.
So so what I felt was this, and maybe I may be wrong, but this is what different modalities. So probably the latest
We can discuss
modalities
it
and
in
all
short,
those.
ma'am.
No. But your presentation is over, right?
Yeah.
So, I mean, the question probably was little, and that is what I felt. Maybe others may not agree with me, but that is, Madam, Mr. Kotkar, Madam, what do you feel? Nair, sir?
Yes, ma'am. It had to be optic disc examination. How will you examine the disc in optic disc in case of glaucoma, rather than what are the findings of glaucoma?
Yes. Precisely, ma'am. Yeah. Okay. Thank you, ma'am.
Yeah. Okay, so we are done with DY Patil Medical College. Shubhashri and Nisarg, before you share the screen, can you let us know whether you have shifted your presentation to laptop, or should we move ahead with the
Yes, sir. I have started it on laptop only, sir.
Okay, Shubhashri. Yeah. Okay. Yeah, then we'll move ahead to Bharati Vidyapit Sangli. Shubhashri, you can share your screen.
Yes. Yeah. तेरा चल रहा है क्या करना है हाँ अभी हाँ मुझे करना क्या हाँ हाँ कंप्लीट करना है इधर वेटिंग Hello, sir. Is it visible, sir?
The screen is visible. Yeah, open your this thing.
Yes, sir.
PowerPoint.
Good morning, sir. Good morning, everyone. Today I'll be presenting on corneal anatomy and its significance. So,
The PPT is not visible. You have to start your slideshow.
Yeah.
The PPT is not visible.
We can see the screen, but you have not opened the PPT probably.
Now is it? So now is it visible, sir?
Yeah. You just put it on a slide share. Yeah. Slideshow.
Yes, sir.
Yeah. Yes. Yes, Subhashri, we are ready to go. You can start.
So cornea is basically derived from word kerato, which means shield or horn. It is basically a transparent, muscular, smooth, convex outer surface and concave inner surface resembling a watch glass. Then coming to dimension, the anterior surface is elliptical with horizontal diameter being 11.75 and vertical is 11. Posterior is circular 11.5. Thickness is centrally 0.52 and peripherally 0.67. The radius of curvature is 7.8, anterior and posterior 6.5. Refractive power is 0.43 and refractive index is 1.37. Basically, the origin corneal epithelium is from surface ectoderm and rest all from paraxial mesoderm. The histologically it consists of 6 layers, basically epithelium, Bowman's membrane, substantia propria, Tua's layer, and Descemet membrane and endothelium. Coming to layers, first is flattened cell is there in the epithelium, which is chronologically oldest. It has microvilli, which contains macrocalyx and is associated with tear film stability. Apart from that, wing cell is there, which is polyhedral, and it has tight junctions present. Flat nuclei is there, parallel to the surface, with less organelle compared to basal cell. Basal layer has columnar polygonal cell arranged in palisades in the basement membrane. It forms the germinal layer and undergoes mitosis and produces daughter cell, which migrates anteriorly. Desmosomes and zonula occludens are present. It is significant for maintaining the transparency and resistant to the flow, and because of its tight intercellular junction. Apart from that, limbal stem cells are there, which are present in limbus, epithelial, which are basically pluripotent stem cells. The significance is diffuse damage to the limbal stem cells lead to chronic epithelial surface defect and invasion of the conjunctival epithelium to the cornea. Non-epithelial cells are also there, which are present in the periphery of the cornea, and it includes basically wandering histiocytes, macrophages, lymphocytes, pigmented melanocytes, Langerhans cells. So basically, it formed from the periphery and moves centrally with age and in response to keratitis. Basal lamina is the basement membrane which is pars positive. It is present posteriorly, blends with the basement membrane, and anteriorly adhesion complex, which are basically made up of type 7 collagen. Significant when abnormally associated with recurrent erosions and epithelial defects. Applied, it leads to bulla formation if it is like in cases of epidermal dermolysis bullosa, and reduplication lead to abnormal epithelial adhesion and increase in epithelial erosions. The function of epithelium being refractive, it provides a refractive surface of eye. It is a major surface for wound healing, and barrier function also is there. Apart from that, Bowman's membrane is there, which is acellular condensed collagen fiber, type 1 and type 4, type 5 collagen basically it is there. It does not regenerate. It helps in refraction. Stroma, it consists of collagen fiber embedded in the proteoglycan, and it has basically 1, 3, 5, and 6 collagen. Corneal lamella are arranged obliquely in the anterior 1/3 and arranged right angle to each other in posterior 2/3. The stromal cells includes keratocytes, wandering macrophages, histiocytes, and few lymphocytes. It produces ground glass substance that is proteoglycan and collagen fiber during embryogenesis and after injury. Wandering cell migrates from corneal blood vessel site to the site of injury. The significance, the parallel arrangement of the lamella allow easy interlamellar dissection during superficial keratectomy and lamellar keratoplasty. Then it also helps in maintaining transparency. Ground substance of stroma, it consists of hydrated matrix of keratin sulfate and chondroitin sulfate in the ratio of 3:1. Keratin sulfates account for swelling property of the stroma. The function, it acts as a window to right passage or meshes with the surrounding scleral connective tissue and help in maintaining the IOP. Pre-Descemet membrane, also called as Dua's membrane, it is composed of 1, 4, 5, and 6. It is CD43 negative. Descemet membrane coming to elasticity is is one of the characteristic, and it is made up of collagen glycoprotein, and its thickness is 3 mm, and it at birth and 10 to 12 mm at a young adult. It provides resistance to the chemical agent, trauma, and infection and pathological processes.
Your 4 minutes are over. Please
Peripheral,
wrap it up.
endothelium consists of single flat layer of polygonal cell with mosaic on descendant membrane. The cell density is 6,000. The defect is usually filled by polymegalithism and varies from 18 to 20 micron to 14. This is a biomicroscope, specular biomicroscopy picture. Blood supply, it is basically avascular. The nerve supply is basically from trigeminal, which is coming, which gives, it is basically highly high nerve supply is there. It is most sensitive at the apex and least at superior limbus. Sensitivity is lowest in the morning and highest in the evening, and sensitivity decreases with the age. Thank you.
Right. Thank you. That presentation, I can. This is Dr. Subhashri, right?
Yes.
Yes, sir.
So the presentation topic itself is quite huge, anatomy and clinical significance. Although I thought you were focusing more on the anatomy and less on clinical significance. I just wanted to know, from a significant clinical point of view, where, say there is stromal edema and there is epithelial edema. So what is the difference between the two, as in when do you see what, and which affects the vision more?
So basically, epithelium, the basal lamina is a basal cell layer is there in the epithelium, and when it is affected, then we will get epithelium edema. And stromal edema basically appears if the layers of stroma is involved, and stromal edema will cause more damage to the vision. Although epithelial would stromal will cause more diminution of vision.
Okay. Actually, stromal edema affects vision much less because it causes less light scatter than epithelial edema. Anyways, yeah, I think the topic itself was also quite vast, but well covered. You need to rehearse a little bit so you can stick to time. Thank you.
Sorry. Thank you.
Yeah. Do we have Dr. Nisarg? Dr. Nisarg would be talking on vitreous substitutes.
Hello. Yes, sir.
Yeah, you share your screen, Nisarg. Dr. Nisarg.
Right, sir. Is my screen visible, sir?
The screen is visible. Open your presentation.
Okay, sir. So is the vitreous substitute screen visible?
No, that screen is not visible at it. It's not opened up as yet.
Okay, sir. Is it visible now, sir, with the substitute heading?
Yes, it's visible now.
Good morning, sir. Good morning, everyone. Today I'm going to present I'm going to show a presentation on vitreous substitutes.
Yeah.
So generally, vitreous is classified anatomically. It has a base, which you can see here, cortex, and a vitreoretinal interface. So there is a vitreoretinal interface. It is a gelatinous structure. It fills the space between lens and retina. It's non-homogeneous. Mostly it consists of water, 99% is water, proteins around. We have collagen, 2, 9, 6, and we have some hyaluronic acid, like glycan, so hyaluronic acid, 210 sulfate, heparan sulfate, ascorbic acids, amino acids, fatty acids, and various cells like hydrocytes, macrophages. So when do we go for substitution of vitreous? Generally, if we remove more than 2 milliliter of vitreous, or if there is a major vitreoretinal surgery, then we go for substitution. The major properties that we look for in a substitute is that it should be scholastic, they should allow movement of ions, electrolytes, optically should be clear, One-time implementation should work. They should be self-renewable, non-toxic, biodegradable, and they should be readily available and cost-effective. We classify the substitutes as aqueous miscible and aqueous immiscible. In aqueous miscible, we classify more as low viscosity, like balanced R solution, high viscosity, like chondroitin sulfates, viscoelastics like hyaluronic acid and hydroxymethyl cellulose. And we also have aqueous immiscible, like gases like air, SF6, C3F8, liquids like silicone oil, which are lighter than aqueous, and heavier than aqueous. We have chlorinated silicone oil and perfluorocarbons. Then we have experimental substitutes like polymers, so hydrogels, smart hydrogels, thermosetting gels, implants, and cell cultures. Coming to the ocular gases and droplet gases. Firstly, Rosengren used gases for subarachnoidal fluid and diathermy. Norton used SF6 for larger air tamponade. Then we classify the gases as non-expanding and expanding. So in non-expanding gases, we have air and xenon, and expanding gases, we have SF6 and perfluorocarbons. The gases work by four properties: by surface tension, buoyancy, solubility, and biocompatibility. So surface tension, the more surface tension is present in the surface of the any liquid, because of this, there is greater forces of attraction, there are greater forces of van der Waals forces. So these electrostatic forces help in the general retinal detachment as well as pathologies. Buoyancy also works. The gases are able to float due to in the witness, so due to large difference between specific gravity of fluid and gas. Superior tamponades with larger bubble can be seen. Superior tamponade is provided by larger bubbles. It threatens against the eye wall gases. Buoyancy directs the effectiveness of the tamponade. So upward gravitation direction. In gases, we also have to look for the solubility. Solubility of gas in the aqueous medium determines the reabsorption rate of the gas. Biocompatibility, mostly SF6 and perfluorocarbon have a purity of 99.8%, are mostly non-reactive, colorless, odorless. Some side effects are that on contact with corneal endothelium, increased inflammation will be caused by SF6. The dynamics of gases are that they first expand, then equilibrium is achieved with the partial pressure of nitrogen, and then dissolution is achieved. When the gas exits the blood, here we can see the bubble dissolution with nitrogen after nitrogen equilibrium. Gas opposes the posterior end of the brake. It allows the passage of fluid from vitreous to SRF. Blocks the SRF is absorbed into the retinal pigment epithelium choroid. The mostly gas advantages are that it allows visualization of retina, while its optical window allows fluid gas exchange. We inject gases rapidly to avoid fish egg bubbling, 0.3 to 0.5 ml injected. Then coming to the properties, the four known gases we use here are shown. Choice of gas, mainly air and SF6 are used in retinal detachment for diabetic retinopathy, and mostly for RD and macular hole surgeries, we have SF6. Then retinal tears, we use generally.
Yeah, time is over. Please wrap up.
Yeah. Generally, we use injection of 30G needle, 13 millimeter needle, which you have to inject immediately after that. The head position during fluid exchange is this lateral position, and after the post-operatively, there can be some complications like corneal opacities, glaucoma, central arterial occlusion, and in laser treatment there can be anti-cerebral burns. There can be these gas bubble maybe recover the posterior part of the lens, shown as donut sign. If it covers partially, it's sausage sign. We have perfluorocarbons. They enable this to settle posteriorly and open. They allow opening pores in the retina while expressing sublingual fluid. These are the main advantages of these. Five main indications for perfluorocarbons are giant retinal tears, detachment with complicated proliferative vitreous retinopathy, traumatic retinal detachments, removal of pupillary fragments, and macular rotation in the 360-degree retinotomy surgeries. Mainly, they have specific gravity, so effective of in intraoperative repair of complex retinal tears, main advantage. And anterior and posterior segment complications we can manage more easily with perfluorocarbons. Some fluorinated alkynes and then we have silicone oil. Semi-fluid and silicone oil. So basically, silicone oil we use for severe proliferative diabetic retinopathy, macular hole surgeries, giant retinal tears, chronic uveitis with open hypertrophy, fractious retinitis, and endophthalmitis. Some complications silicone oil are cataract glaucoma, blind keratopathy, emulsification of silicone oil may be there, retinopathy may occur post-operatively, and recurrent detachment. Diagram shows the cataract. This diagram This is fine gravity due to silicon oil.
Please wrap up, please.
And the silicon is into chamber. So emulsification may occur after a silicon oil injection. Some main advantages are that it requires higher cell tension. There is ease of withdrawal and silicon oil requires a temperate effect on super retina. And some experimental substitutes that we use can be for the molecular structure, which is molecular structure requires cooling function to control elasticity, pressure of dye. The chemical and physical properties provide diffusion of metal mixing gases for presenters and integrate extracellular structures. Some experimental substitutes that we have observed or investigated are natural polymers like hyaluronic acid, collagen, hydrogels, which are called soy gels, and some transplants and implants like FCV PVA filling model and silicone oil injected to a wall system. Thank you.
Yeah, Nisarg, it was a very extensive presentation. It's a big topic, I agree, but still probably you should have stuck to time because time is important. You were given 4 minutes. You could not talk much about silicon oil and all. I would just like to know, when do you prefer to use silicon oil, the common one, and the other is heavy silicon oil? What is the difference? And when do you prefer to use the other one? In which condition?
Ma'am, heavy silicone oil can be used in to achieve when there are giant retinitis.
Sorry?
Heavy silicone oil in cases, ma'am, if there is giant retinal tear. And
any
in
particular
cases
site? Any particular site?
Ma'am, if there is inferior detachment, then.
Okay, thank you.
Okay, then we are done with the presentation, Nisarg. You can stop your screen here. We'll move ahead to the next college, that is Krishna Medical College, Karad. Do we have Dr. Sanjana here?
Yes.
Yeah, Dr. Sanjana, you can share your screen. Dr. Sanjana would be talking on dyes in ophthalmology.
Yes. Yes. Is it visible now, sir?
It was visible for some time, but yeah, it's visible now. Yeah, you can start your presentation, Sanjana.
Good afternoon, everyone. I'm Sanjana Hegde. I'll be presenting on dyes in ophthalmology under the guidance of Dr. Gaurav Parantake, sir. And the objective of the session is that at the end of the session, I want everyone to be able to tell the uses and importance of dyes in ophthalmology. Although dyes are a non-invasive diagnostic procedure that is used to visualize microscopic ocular structures for the anterior as well as posterior segment disorders. So in clinical practice, dyes help in better visualization and aid in diagnosis of ocular surface disorders. And in surgical practice, it helps in better resolution of the structures that are otherwise naked to the surgeon's eyes. So these are the different dyes that we commonly use in practice and which I'll be talking about. So first is the fluorescence dye, which is usually mainly used in everyday clinical practice to diagnose and monitor the progression of corneal ulcers, and it aids in the management as well. It's used in diagnosis of dry eye disease, in applanation tonometry, in diagnosing perforating injuries by Siegel's test, nasolacrimal duct patency by Jones dye disappearance test, fundus fluorescence angiography, and in assessing contact lens fitting. Another dye that is used is lizamine green, which is a synthetic dye. It is also used in diagnosis of dry eye disease. Circumlimbal staining can indicate contact lens-induced conjunctival staining, and it can be used in diagnosing lid viper epitheliopathies. Rose Bengal test is a dye that is a halide derivative of fluorescein. It stains devitalized tissues. Like fluorescein is used for corneal staining, Rose Bengal is used for conjunctival staining. It is also used to stain the margins of dendritic ulcers and in meibomian gland dysfunction. It, due to the issues of toxicity and stinging sensation, it is less used now. That's why lizamine green was invented. Coming to dyes that are used in surgical practice, the most commonly used dye that we use in cataract surgeries is trypan blue. It stains the anterior capsule of the lens, providing a contrast and easy visualization of the anterior capsule and helps in capsular excess. It is also used in DSEC and DALP to stain the different layers of the cornea, and it is not toxic to the endothelium. It stains the Tenon's capsule, aiding evisceration, and stains the ERM. Indocyanine green is also another dye that is used to stain the anterior capsule of the lens, visualize the ILM, and it's used in indocyanine green angiography. Compared to fundus fluorescence angiography that you see in figure A, indocyanine green angiography is helpful in viewing choroidal circulation. The next, indocyanine green is also has a property of decomposition. So therefore, it is used less. Triamcinolone acetonide is another dye that is used to stain the vitreous. So this is useful in cases of any posterior capsular rent in cataract surgery and during vitrectomy. So it stains the vitreous and it helps differentiate between areas clear of the vitreous and areas with the vitreous and enables its removal. The issue with triamcinolone acetonide, though, it remains in the system for 40 days. So in case it's there, it can accelerate the process of cataract or increase the intraocular pressure. Brilliant Blue is a FDA-approved dye for ILM staining. It has two properties, negative staining and double staining, that we use. It has a strong affinity for internal limiting membrane without staining the epiretinal membrane. Therefore, we use this to peel off the epiretinal membrane and then stain the internal limiting membrane. Again, that is called double staining. Verteporfin or Visudyne is a photosensitizer for photodynamic therapy to eliminate the abnormal blood vessels in the eye, which is usually used for age-related macular degeneration and bed form of macular degeneration. These are the references that I've used to make this presentation. And I would like to acknowledge the organizers of Maharashtra Ophthalmological Society, IHOD V.H. Karumilkar sir and Gaurav Paranjpe sir. Thank you.
Very nicely explained dyes in ophthalmology, Sanjana. What I would like to know is what precautions will you take before injecting fluorescein dye in body?
First precaution is there are high chances of allergic reactions in fluorescence angiography. So we have to keep a crash cart available with important dyes like Avil and Hydrocor, and always ask for proper history of any past, any allergy to any medications, any renal issues, or any other systemic illness that could predispose the patient to having an allergic reaction. And also in pregnant females, we don't usually recommend fundus fluorescence angiography.
Okay. Thank you.
Thank you.
Okay, thank you, Sanjana. Then we go on to the next presenter from Krishna Medical College, that is Dr. Tanaya. Dr. Tanaya, are you here?
Yes, sir. Yes, sir.
Yeah, share your screen, please. Dr. Tanaya would be talking on DDs of limbal mass.
So is my screen visible?
Yeah, your screen is visible.
Okay.
Yeah,
So
you
my
can
name
start
is...
with your presentation. Yeah.
Okay, sir. So my topic for today is differential diagnosis of limbal mass. So as we all know, limbus is a junction between the sclera and the cornea, which is about 1 mm wide. It contains multiple horizontal ridges called palisades of Bow. The epithelium is made up of 8 to 10 layers of stratified squamous cells. So cause of limbal mass can be divided into congenital and acquired. These are the following headings under which I'll be elaborating further. Coming to congenital causes, first is dermoid, which is basically seen in early childhood. It is a choriostoma and seen in perotemporal limbus with protruding hair. Treatment is simple excision or laminar keratosclerectomy. It is commonly associated with golden heart syndrome. Then we come to dermolipoma, which is similar to dermoid, but it also has adipose tissue. The treatment here would be debulking the anterior portion for cosmetic effect. Then raised nevus. So nevus can be flat or raised, has a tendency to grow during puberty and pregnancy. And the treatment is excision. Inflammatory causes, we have nodular episcleritis, where females are affected more. There is a tender vascular nodule within the intervalvular fissure. The treatment is cold compresses, topical steroids, or NSAIDs. Then nodular scleritis, which is far more painful than nodular episcleritis. There is insidious onset of pain and tenderness of the globe. Here again, the treatment would be steroids. Coming to allergic causes, we have vernal keratoconjunctivitis. It is basically a recurrent bilateral disorder due to hypersensitivity to pollen and dust. So here the characteristic feature, as you can see in the picture, is Horner-Tranta spots. They are gelatinous limbal conjunctival papillae with cellular collections. The treatment here again is steroids, mast cell stabilizers, and NSAIDs. Then flictin, they are pinkish white nodules surrounded by congestion. It is basically an endogenous reaction to tuberculous protein. So treatment is topical steroids and treatment of the underlying cause. Traumatic causes, we have granuloma, which is seen after ocular surgeries like squint or pterygium surgery. And the treatment here is again surgical excision. Degenerative causes, pinicula, which is commonly seen in the nasal side of the eye. Highline occurs in elderly. Treatment, topical lubrication, excision, and thermal laser ablation. Then cystic pterygium is seen after a recurrence of a normal pterygium. Treatment is excision and autoconjunctival transplantation. Coming to neoplastic causes, now limbus is a site of high mitotic activity, so more prone for neoplasms. Papilloma, which is associated with human papilloma virus 6 and 11. It is a benign polypoid tumor. It can be sessile or pedunculated. And here you can see the feeder vessel on the tumor. Treatment is excision with cryotherapy. Then squamous cell carcinoma, where it invades the underlying structures. Basically, it's a fine granular growth and requires early excision and topical chemotherapy. Conjunctival melanoma, as you can see, it's a black or gray vascularized nodule. Histologically, there is cellular atypia. Treatment is excision with adjunctive radiotherapy. Coming to miscellaneous causes, it can be because of filtering bleb that is seen post-trabeculectomy or retention cyst of conjunctiva. Basically, it's a cyst filled with clear fluid, and the treatment again is surgical excision. In intercalary staphyloma, there is a bulge in the limbal area lined by root of iris due to ectasia of weak scar tissue. It is generally seen after healed perforation injuries or corneal ulcer. So these are my references. Thank you.
Yeah, well presented, but you finished nearly half a minute before your time. What few of the other presenters would not give for that additional 30 seconds. So I just wanted to know epidemiologically, based on numbers, which one is the
So you're not
most...
very audible.
Yes, sir. Yeah.
Okay,
Sorry,
just
sir,
give me
can't
1
hear
second.
you.
Yeah.
Okay, is it better? Can you hear me now?
Yes, sir. Yes, sir.
Yeah. So I said in terms of numbers, which one is the, in adults, which would be the most common limbal mass that you see?
In adults?
Yes,
So,
in adults.
mostly cystic pterygium we can see, sir. Are you asking about neoplasm or in general, sir?
Let's talk about neoplastic lesions.
So a papilloma can be seen, but it is a benign polypoid tumor. And in case of conjunctival melanoma, this malignant lesion is called conjunctival melanocytic.
No, ma'am. My question was, what is the most commonest malignant limbal lesion that you see?
It would be papilloma.
Okay. Yeah. In adults, because especially in the Indian subcontinent, what we see is ocular surface neoplasia as common lesions because of sunlight exposure and stress. And any particular screening that you do for these patients with OSS?
So basically, for in such cases, occupation is very important. Like if the patient constantly in dry, humid weather, or constantly in the sunlight or exposed to UV radiation, so they have more chances of developing OSSN. And so USG can be done in this scan.
No, actually, systemic screening is what I meant.
Okay, so you can screen for. Sorry, sir.
Yes, most common, typically most of these patients need to be screened for any sort of immunosuppression like HIV, etc.
Yes, sir. HIV and rheumatoid arthritis, TB, they can be screened for that. So.
Thank you.
Thank you, sir.
Okay. Thank you, Tanaya. With that, we finish Krishna Medical College. we'll move on to the next college, that is Bharati Vidyapit Pune. Do we have Dr. Rishabh here?
Yes, sir. Good afternoon, sir.
Yeah, Rishabh, you can share your screen. Dr. Rishabh will be talking on refraction in children. Yeah, your screen is visible.
क्या बुला रहे हैं मुझसे? हैं? क्या हुआ, बुला रहे हैं?
Hello. Good afternoon,
Yes,
sir. May I start?
Yeah, you can start your presentation, Rishabh. Yeah.
Good afternoon, everyone. My topic is refraction in children. Okay, let us first start with the topic itself. The first term, refraction. The basic of refraction. Okay, the term refraction, the basic physics term, it is bending of light rays when passing through different medias. So in our eyes, we have 4 different medias that the light rays pass: cornea, aqueous humor, lens, and the vitreous. And the light rays are basically focused on the retina. The second term, which is children, is very important because it is important to know the development of visual system of the child. At birth, the eye of child is around 75% size of the adult eye. So it is hyperopic, plus 2 diopters. As the baby ages, during the first 2 to 3 years, emmetropisation is completed by around 3 years. And also the age groups are important because each age group has its own challenges and guidelines for prescription. Let us quickly go through the refractive errors: the myopia, hyperopia, and astigmatism. Myopia, as we all know, is the image is formed in front of retina. Hyperopia, image is formed behind the retina. And astigmatism, instead of a point focus, there is 2 lines which are focused, separated from each other. So children might not always be able to communicate their vision problems. So it is important for parents to observe what signs and symptoms that he or may have. Squinting of eyes, holding objects too close, complaints of blurred vision, especially like elder kids, around adolescent kids, difficulty seeing blackboard, and occasional headaches. It is very important for early detection of refractive error to prevent or treat amblyopia. And also, the parents are concerned about the underperformance of child in school. There are a few challenges that we encounter while we do refraction in children. The children are uncooperative. They have a great range of accommodation, and they're difficult to quantify the visual status. Before we start refraction, it is important to assess the visual acuity and to rule out any strabismus using cover test. A Bruckner test can also be used to quickly see whether the patient has myopia, hyperopia, or even strabismus. Let us start with refraction. ELDEC is usually we can do subjective refraction, but objective refraction must be done in all children. Starting with retinoscopy. Retinoscopy allows the observer to accurately measure a patient's refractive error by determining the sphere, cylinder, and the axis of the cylinder power. The setup requires a darkroom, working distance of usually arm's length, and cyclopegia. The examiner obtains a red reflex with a streak of light. If we get against the moment, we add minus lens. And if we get with the moment, we add plus lens until we achieve a neutralized area. And we record it in a cross for both right and left eye, both meridians. However, the final assessment of refraction is given only after the cyclopegia effect is eliminated. The cyclopegia helps determine the total refractive error, which otherwise doesn't manifest on subjective non-cyclopegic refraction. So atropine is slow to act and has relatively more side effects. Hence, cyclopentolate is the most commonly used, except in case of seizure history when we try to use hometropine. Now, once a child's refractive error has been determined, the next decision is whether or not to prescribe the corrective lens. The following guideline, as we know, is from the American Academy of Ophthalmology that we follow. In this, we can see that as the age increases, the threshold becomes more and more stricter. This is in order to prevent amblyopia. And also, if the patient has strabismus and anisometropia, it is even stricter.
Your time is over. Please wrap up.
Thank you, sir. Thank you.
Okay.
Nice presentation. The big topic, but the presentation is good. Can you just elaborate on subjective refraction methods in children? Subjective correction of refractive errors. Any
Yes, ma'am.
specific method? Yes, in children.
Ma'am, there are
Okay. Yes. Yeah.
ma'am, we have various visual acuity charts for children, pediatric charts that we can use.
Yeah. Okay. Supposing the child has come to you without I mean, cycloplegia, you want to have cycloplegia and then somehow you are not able to do it for some reasons. Is there any method that you can use for eliminating, for assessing the hyperopic component?
Then we can use
Any
a
test?
dynamic retinoscopy can be used, which doesn't require cycloplegia. The accumulative effect is maintained in that case.
Yeah. Yeah. Okay. Thank you.
Yeah.
Thank you.
Okay, we can move on to the next speaker. Dr. Ishwari, are you here?
Yes, good afternoon, sir.
Yeah, good afternoon. You can share your screen, Ishwari. Dr. Ishwari will be talking on newer IOLs.
Can you see my screen, sir?
Yeah, your screen is visible.
Good
You can
afternoon, everyone.
start.
I'll be starting on newer IOLs. First, starting briefly with the history of IOL. The IOL was first implanted by Sir Harold Ridley in 1949. He had observed that PMMA particles from fighter pilots, the windshield of fighter planes, could be inserted in the eyes of pilots, and emmetropization could be achieved. Coming to newer IOLs, first type is the multifocal IOL. The normal IOL that we see are unifocal, that is, they correct only the distance vision. But multifocal IOLs are able to correct both near, distance, and intermediate vision. This technology works on the brain's ability to select the clearest image. There are two types, refractive and diffractive. In refractive optics, the refractive IOLs have an annular zones of different paths which provide focus from far and near. They provide better intermediate and distant vision, and near vision may not be sufficient. But these IOLs are pupil dependent and they're sensitive to minimal decentration. There are two types of refractive IOLs, two-zone and annulus. In two-zone types, they just have two zones. That is, the central vision corrects the near vision and the peripheral part corrects the distance vision. In annulus types, there are concentric zones. The central part is for the distance, and the peripheral rings are also for the distance, and this intermediate zone is for near vision. So example includes array multifocal IOL, resume multifocal IOL, and prezoil. In diffractive IOLs, the anterior surface of the lens is smooth, whereas the posterior surface has these steppings. These steppings create a distortion in the surface, creating diffraction. So different points focus different wavelengths, and we get three focuses, that is for distance, intermediate, and near. And apodization is the gradual tapering or the gradual increase in the size of these stepping, so that we get better quality of intermediate vision. But diffractive IOLs lose 18% of light, and the remaining light is divided into two foci, 41% for distance and 41% for near. Due to this loss of light, there is decrease in contrast sensitivity in these IOLs. So these IOLs are good for distance and near vision, but they have an acceptable intermediate vision. They are less pupil dependent and tolerate decentration. But the disadvantages due to loss of light is that they produce scattering and have glares and halos. Example include the Technis multifocal IOL, Acris of IQ Restore, and Panoptics. So this is the refractive multifocal IOL. There are concentric zones or rings which provide different refractive indices as we go throughout the lens. Whereas in diffractive, the anterior surface is smooth, whereas the posterior surface has these steppings. So they distort the surface, producing diffraction. Accommodative IOLs are based on the Helmholtz theory. That is, with contraction of ciliary muscles, there is zonular laxity, which allows the lens to increase its anterior-posterior diameter and increasing the refractive power. So mechanism of accommodating IOLs is by change in actual position or change in the shape. In single optic design, the haptics contract and the IOL bulges forward or forward movement is seen, which increases the anterior-posterior diameter. So crystallens, tetraflex, and 1CU are examples of single optic designs. In dual optic, the anterior component has a high plus power and the posterior component has a minus power. So they negate each other, making the eye emetropic, and these two optics are connected with a spring. They're currently not commercially available but under research. Second type is based on the changes in the shape or curvature. First is the fluid vision type, in which the haptic and the interior of the optic are filled with silicon oil. So while accommodating, as the haptic contracts, the silicon oil migrates from the haptic into the optic and increases the AP diameter. In new lens, new lens also has silicon oil, but the silicon oil is in a solid form. So when the piston contracts or is pressed, the silicon oil bulges. So this again increases the AP diameter. New lenses are not commercially available. Toric IOLs are for correcting astigmatism. They are indicated in patients with more than 1 degree of astigmatism, regular astigmatism, and lenses are available. 1.5 to 6 diopters. The axis of rotates by 3 degrees. There is 10% loss of the effective vision. So if the IOL rotates by 30 degrees, there is complete loss. Special functions include for aniridia, where iris is absent. So the lens has a central clear zone and a periphery of opacity, which acts as an iris diaphragm. It reduces glare and photophobia. Implantable telescopic lenses are micro lenses which have an increased refractive index in the center. So it is indicated in patients with age-related macular degeneration who have central vision loss. Piggyback IOLs are IOLs which are implanted in front of the normal IOL, or this is done in cases of patients having high refractive surprise. So a second IOL is implanted to make the patient emetropic. Recent advances include injectable gel form of IOL, where femtosecond surgery is done and an IOL is inserted in the gel form or a polymer form, which produces emetropization. Light-adjusted IOLs have special macromers that get photopolymerized upon hit with a certain wavelength of light. So when light falls on this, we can adjust the amount of light which is thrown onto these lenses to make a refractive index in such a way that the patient is rendered emetropic. And the latest advances are the high-tech intraocular pressure sensing implanted IOL. They are useful for patients having glaucoma. So they have microelectronic sensor that measures the intraocular pressure. So there are the 3 types of IOLs. Monofocal IOLs correct only distant vision. Toric lenses correct astigmatism, and multifocal corrects all 3, that is distance, intermediate, and near visions. They can also correct astigmatism. So yeah, thank you.
Very well explained, Dr. Ishwari. I have a query here. Suppose a driver comes to you. He's a driver by profession. Which type of intraocular lens would you implant?
Ma'am, I will suggest a unifocal IOL in this patient.
Why?
Because it takes a long time to get adjusted to multifocal IOLs, and many times the patient satisfaction is not as good as patients having unifocal IOLs. So if the occupation is driving, he should have a lens which gives him the best possible vision.
Your answer is correct, but the answer would be, the explanation why we will not put will be something else. Okay, thank you.
Okay, thank you.
Okay, we'll move on to our next college then. Next college is D.Y. Patil Medical College, Pune. Do we have Dr. Shreya here?
Yes, sir.
Yeah, Shreya, you can share your screen. Dr. Shreya will be talking on biometry.
Good afternoon, everyone. My topic is ocular biometry. As we know, it's a vast topic, but I'm going to try my best to cover it in the allotted time.
Yes, you can start.
Yes. So biometry is the measurement of the ocular anatomical dimensions. It includes keratometry, measurement of the axial length and effective IOL position. Keratometry is the measurement of the refractive power of the cornea, And the one diopter error in the corneal power causes one diopter post-operative refractive error. It is measured using manual keratometry, autorefractometry, pentacam, and IOL master. Axial length is the distance between the anterior surface of the cornea to the retinal pigment epithelium, with the normal average axial length being 22 to 24.5 millimeters, and an error of 1 millimeter in the axial length causes 2.8 to 3 diopter change in the IOL power. A scan is the amplitude scan is a diagnostic test which helps in measuring the axial length of the eye, in which the probe is placed over the anterior surface of the cornea, which results in the spikes which are shown on the display monitor.
Go ahead.
The first two spikes are the anterior and the posterior surface of the cornea, followed by the anterior and the posterior surface of the lens. Between the posterior surface of the cornea and the anterior surface of the lens is the anterior chamber, followed by the vitreous and the echoes from the retina, the sclera, and the choroid. There are different types of biometry, which includes the contact biometry, emotion biometry, and the optical biometry. In the contact biometry, there is a handheld method and the applanation method. But in both of these, there is a risk of corneal compression, which can give false results. Whereas in immersion biometry, it uses a Prager scleral shell, which is placed between the lids and filled with fluid up to the mark, where the probe is inserted, but it does not touch the cornea, so there is no risk of corneal compression. In optical biometry, there is LensStar and IOL master. In LensStar, it is based on the optical low coherence reflectometry, which uses a superluminescent diode laser, which is 820 nanometer in frequency. The pupillometry, the lens thickness, and the central corneal thickness can be measured here. In IOL master, it uses the principle of partial coherence interferometry, in which infrared diode laser is used of 780 nanometers, and in the IOL master 500, the pupillometry, lens thickness, and the central corneal thickness cannot be measured. The effective IOL position is determined by the anatomical factors, the IOL factors such as the shape, length, and the IOL material, the surgeon-related factors, and the back to sulcus shift, which might be required in situations like a posterior capsular rent or the loss of the anterior capsular integrity. There are different formulas for IOL power calculation, which is extending from the first generation to the fifth generation, which I'll be discussing further, where the newer formulae are the Barrett Universal 2 formula and the Hill RBF formula. In the first generation, or the SRK1 formula, it was introduced by Sanders, Retzlaff, and Kraft, and it states that P is equals to A minus 2.5 L minus 0.9 K, where P is the IOL power, A is the constant, K is the average keratometry in diopters, and L is the axial length. The second generation formulas are the SRK2 formula, the modified SRK2 formula, and the Hofer formula, where the SRK2 formula and the modified SRK2 formula are based on the baseline of SRK1 formula, but the A constant is added depending upon the axial length of the patient. In the third generation, the Hofer-Q formula is best for small eyes. The other formulas are the SRK-T formula and the Holiday 1 formula. For the fourth generation, there is the Holiday 2 and the Hagees formula. The Hagees formula measures the other parameters measured in the previous formulas, as well as the effective lens position, which has three constants, A0, A1, and A2. The fifth generation is the Hofer H5 formula, which considers the demographic specifics of the individual in addition to the other parameters. There are various guidelines for different formulae. The SRK2 is accurate for axial length between 22 to 24.5. Hofer-Q is the best for small eyes less than 22 millimeters. And SRK-T is best for long eyes more than 26 millimeters and aphakia. Biometry can also be done in special conditions like in aphakic, pseudophakic, post-vitrectomy, and keratorefractive surgeries. Done in for eyes requiring a secondary IOL implantation in aphakics, and in pseudophakics requiring IOL exchange.
Time is over. Please wrap up. Yeah.
Yes,
Yeah.
these are my references. Thank you.
So, well presented. Hello, can you hear me?
Yes, sir.
Yeah. So I wanted to know, the latest technology, like you mentioned, is the IOL master or ones that are based on the principle of using an ultra bright diode. So what conditions do you think will an IOL master not be adequate or will fall short? Or what are the limitations?
So in patients who are unable to fixate, if they have a mature cataract, or if they have any dense corneal opacities, or if there is any dense opacities in the vitreous, saying vitreous hemorrhage, or any tumors or anything that is obstructing his vision, which prevents him from fixating, or a vision less than 660, then he will not be able to, then the measurements will not be accurate, sir.
Yeah, so would you think visual acuity is a criteria for IOL master?
Yes, sir, because the patient is supposed to fixate while sitting at the, it is a non-contact procedure. So if the patient cannot fixate and if the visual acuity is very poor, then he will not be able to, then the measurements will not be accurate.
All right. So what will you do in these cases?
So we can do a contact biometry, a handled or an applanation, and go for the conventional A scan, sir.
All right. Thank you.
Yes. Thank you, sir.
Yeah, we're done with Dr. Shreya. Do we have Dr. Tushar here?
Yes, sir.
Yeah, Dr. Tushar, please share your screen. Dr. Tushar will be talking on treatment of neovascular glaucoma.
Is my screen visible?
Yeah, your screen is visible. Yeah, you can start your presentation.
Good afternoon, everyone. So I'll be talking about is the management of neovascular glaucoma. So first, talking about the basics of neovascular glaucoma. So why are we talking about this topic is because it causes a painful blind eye, which is a very important condition. So it is a sight-threatening secondary glaucoma, which is characterized by new vessels, which leads to progressive angle closure and rapid glaucomatous optic atrophy. So if we see this diagram, so in this we can see there are these vessels that are growing around the pupillary area. So if we talk about the etiology of neovascular glaucoma, so the most important factors, that is the proliferative diabetic retinopathy and the central retinal vein occlusions, are the two most important conditions which lead to neovascular glaucoma. There are many other conditions or etiologies which can be discussed, but the main important are these two. Going ahead, so exactly what happens is as soon as there is retinal hypoxia or ischemia, the vascular endothelial growth factor growth occurs, and the angiopoietin 1 and 2 play a role, because of which the neovascularization from the posterior chamber goes from the pupillary area to the anterior chamber, which leads to more sequelae, that is the pre-rubiotic, rubiotic, the open angle, the closed angle, and the burnout stage. So these are the clinical features. The most important part is neovascularization of the iris and the neovascularization of the angle, which can be seen on gonioscopy, the UBM, that is ultrasound biomicroscopy, and the fundus fluorescent angiography to see the capillary non-perfusion areas. So talking about the prevention, which is the most important part, that is the treatment of the retinal ischemia with the help of intravitreal bevacizumab injection, the panretinal photocoagulation. If the media is unclear, then we go for anterior retinal cryotherapy and vitrectomy if there is vitreous hemorrhage involved. We need to control the intraocular pressure with the help of medical management, the glaucoma drainage devices, and the cyclophotocoagulation, and to control the inflammation, that is the steroids and the cyclopegia. So this is the most important chart. If there is neovascularization of the iris on the angle, we check for the intraocular pressure. If there is retinal ischemic disease, then we see whether the media is clear or not. If the media is clear, then we go for panretinal photocoagulation and the use of intravitreal injections, that is bevacizumab, which can be put in the pars plana loop. And nowadays, the studies are going on to consider that in using intracameral anti-VEGFs. If there is an inflammatory disease, then we go for steroids and cycloplegics. And if the media is not clear and the disease is limited to the aura, then we can go for anterior retinal cryotherapy or pars plana vitrectomy with endolaser. If there is no PL, then and the patient is having pain, then we can go for cyclodestructive procedures through which there is destruction of the secretory function of the ciliary epithelium, which leads to decreased aqueous secretion. Then there are other things, that is, we can go for transferal cyclophotocoagulation and so on. So talking briefly about all these conditions, first of all is the panretinal photocoagulation, which makes the ischemic retina anoxic, reduces the neovascularization, and these are the parameters which are used here. Next is the medical management with the use of topical beta blockers, oral and topical carbonic anhydrase inhibitors and oral acetazolamide. We use the intravitreal bevacizumab, that is 1.25 mg per 0.05 ml. Then is the gonio-photocoagulation. Using the gonioscope, we do the laser therapy. Next is the anterior retinal cryotherapy when the media is hazy. Next is trabeculectomy. So there is higher rates if you use trabeculectomy with mitomycin and preoperative bevacizumab, the success rates increase. And if you use the glaucoma drainage devices such as the Berwelt, the Express, and the Ahmed devices. And next is the cyclodestructive procedures, that is cycloablation, the cyclocryotherapy, transferal cyclophotocoagulation, and the retrobulbar alcohol injection. These were my references. Thank you very much. Hello.
Yeah.
Yeah.
That was a good presentation. Can we hear from our judges, please?
Dr. Shubhangi?
As ma'am, I think I don't know whether she's.
Yeah, Dr.
Ma'am, are you
Shubhangi
there?
or Dr. Akshay, you can go ahead. Yeah.
So I would like to know, when will you do, how will you prevent this neovascular glaucoma?
So we check for
Prophylactic measures.
Yeah, so we check for the etiological agents. So first of all, the most important part is to if the patient is diabetic, we check we screen the patient on regular intervals. If the patient is going towards proliferative diabetic retinopathy, then we should consider for anti-VEGF injections like bevacizumab or ranibizumab injections to limit the vascular endothelial growth factor. Next is if the lesions are treatable with the help of lasers, then we can go for pan-retinal photocoagulation. So treating the etiological agents is the most important part. If that is also not being able to, if we are still not able to prevent that, then only we go for the higher things, that is the surgical part.
So once the neovascular glaucoma has set in, which will be the best surgical modality to control it? You have said so many, but you did not mention when will you do a cycloablation or a gonio-photocoagulation or a shunt or a trabeculectomy. So which will be the best out of these in a seeing eye?
So, ma'am, if the intraocular pressure is not under control with the help of medical therapy, then
It will never be, no? Neovascular glaucoma is not a medical, cannot be controlled medically.
Yes, ma'am. So then, ma'am, if the patient is having pain and the pressures are high, so we'll go for trabeculectomy with the use of glaucoma drainage devices.
Okay, thank you.
Thank you, ma'am.
Well, I'm sorry, I was having some call. Thank you, Mr. Kotikar, madam, for asking the question.
Yeah, do you want to add anything, ma'am? If you want to ask, we can go ahead. Jyotika.
No, it's okay.
Okay. Okay, ma'am. That brings us to the end of our presentations and sessions for today. I would like to thank all the mentors. I would like to mention their names here, because we didn't mention it in the beginning. Dr. Nandadeep, the Nandadeep Hospital team was mentored by Dr. Komal. DY Patil Kolhapur team was mentored by Dr. Supriya. Bharati Vidyapit Sangli was mentored by Dr. Rajesh. Krishna Medical College by Dr. Gaurav Paranspe. Bharati Vidyapit Pune by Dr. Sanjeev Agarwal, and DY Patil Pune by Dr. Ikra Mushtaq. All of them have done a wonderful job, and we've seen that they have trained their PGs very well, and all of them presented well. I would also like to thank all our esteemed judges, Dr. Jyotika, Dr. Shubhangi, and Dr. Akshay, for taking time out of their busy schedule and helping Maharashtra Ophthalmic Society to conduct this activity.